Okay, can everyone hear me?
Mm-hmm.
Yes.
Okay, perfect. Okay, so let's get started. Good evening, everyone, and welcome to the Beyond Sixth Year event. My name is Moyo, and thank you all for taking the time to RSVP and tune in. I'm sure that we're all going to take a lot away from this panel, a lot of valuable information, a lot of insight. So today's event is focused on the journey after graduation and the road to becoming a specialist, particularly in the field of internal medicine. I'd like to start by extending a warm welcome to our doctors on the panel today. So we have two interns, Dr. Tapiwa Sibanda and Dr. Aishwarya Luke. We have our ComServe doctor, Dr. Leonard Muhango, who I'm sure a lot of you know. We have our physician, Dr. Tina Ingratta, and our cardiologist, Dr. Farouk Mamdoo, which some of you may know headed our cardiovascular block. So thank you so much to the doctors for taking time out of your busy schedules to join the panel today and give us some insight into life after graduation. So we're going to start with our interns and what they have to say and work our way along the panel. And then at the end, we'll have a few questions that students have submitted to us. Thank you. Any one of the interns can begin, whether Dr. Sibanda or Dr. Luke. Yeah.
I think I'll start because I'm actually on call tonight, so I might have to leave early. I'm Aishwarya Luke. I'm an intern at Chris Hani Baragwanath at the Academic Hospital. I studied at the University of the Witwatersrand. Shiraz and I actually started the society back when I was in fourth year, so it's nice to see how it's grown since then. So I was given a few questions. So my first question was, how does placement work for internship, and do you get to choose? So it differs. Every year has been a new application system, depending on what the number of interns applying and the number of posts available. So how it worked for us is around June, ICSP came and had a talk with us, explained the whole internship system to us, that it's a 2-year program. And we had to register with the ICSP website. Basically, they just asked for our personal details, our ID numbers, and then for our HPCSA registration, and whether or not we were citizens, permanent residents, or foreign nationals. After that, it was basically a waiting game. We were able to apply around September, October, and how the applications worked, we were given 5 options, and we rated them from our most desirable to our 5th choice. And we, at the time, we were allowed to apply for, I think, as many priority 3 hospitals. So priority 3 would be our tertiary hospitals as we wanted, and at least 3 priority 1 hospitals, and only 1 metropolitan. Obviously, I don't know what the application system is this year, but the final years usually get they get an introduction by ICSP as to how the program is going to work. So what influences the decision? So it's quite multifactorial. So one would be which city or town you would like to do your internship. So for me, I had some personal considerations. I'm married. My husband is also a doctor, and I didn't want to leave Joburg. So my choices were all based in Gauteng. But it was also based on the amount of experience I wanted, exposure, and just the patient load. So I chose Bara because it was a good academic setting. I have an interest in internal medicine, and I know that the patient load here is very vast, and I'd have good exposure. But I also wanted supervision during my internship. So the nice thing about academic hospitals is that you're always supervised. There's always a registrar around, there's always a consultant around to guide you, and to correct all the decisions that you make, and to supervise all your decisions. The downside on it is that you don't get as much practical exposure as you would in the peripheral hospitals. So, especially now in COVID. So, it depends what you want and what you want to get from internship. So, a hospital like Barra, you have to realize that you're also giving up a bit of your social life. Internship is very demanding, and um, weekends are a privilege. They're not a right. So, in my 6 months of internship, I think I've had a total of 5 free weekends. Um, so it really depends. Other hospitals are a bit better, but for those of us who applied to Barra, I don't think we mind giving up our weekends. Um, then how does it how does it impact your specialization journey? So as far as I understand, the hospital you choose doesn't give you any um, extra points for your specialization. Um, Specifically for internal medicine, um, it would only impact the exposure. As far as I understand, you won't get any extra points for doing it at a tertiary hospital versus a district hospital or regional hospital. Um, so things to consider when applying for internship, I think I've basically covered all of that. It depends where you want to go, what you want to get from internship, social life versus hospital life, and the support structures that go with each hospital. Then transition from medical school to internship. Uh, I don't think you can ever be prepared for internship. It's whether you're the best student or the worst student, internship is rough and it's scary, because for the first time you have patients' lives in your hands and you actually have to make decisions, um, and and your decisions actually impact people's lives. So if obviously the better you prepare at med school and the more knowledge you have, the more equipped you'll be to deal with different circumstances. But basics are so important. So you won't need to know how to manage very severe, complicated lupus, but you need to know how to shift potassium. You need to treat hypoglycemia. You need to treat a basic DKA. So for me, treating emergencies going into internship is very important, and being well read around that. The first few times you have to do a resus or you have to treat an emergency is a mess. You kind of lose your calm. You don't know how to handle the situation. You get very frazzled. You do things in the wrong order, which is natural. But the whole point is to go read around whatever situation you encountered and do better the next time, and try and improve on your previous experience, and always call for help. Don't try and handle things that you don't know anything about. Internship, there should be supervision at all times, and you might feel like an idiot in the moment for not knowing very basic things, but it's better for you to ask for help than to run into a situation that you don't know anything about. Did medical school prepare us or equip us well enough? Um, so it depended on the rotation. It depended how involved you were as a student, and it depended what kind of supervision you had um, during med school. So for me, I felt like I was quite well exposed as a student. I was very involved with ward rounds and with daily um, ward activities. And I always made sure that whatever unit I joined as a student, I became part of that unit. It really helps a lot, especially doing basic things like bloods, drips, filling out forms, going with the intern to book things. It does help you when you start off, to be more involved and part of the team when you're a student, and also gives you a bit more confidence going into internship. Uh, Being an intern during COVID. Yeah, so I think our internship experience is very unique. It has affected us in a lot of ways. So the rotations I've completed so far are pediatrics and surgery, and I'm currently in internal medicine. So pediatrics, COVID was not a big thing, and pediatric patients weren't affected so much during the time. So, so I wasn't really affected. But during surgeries, I felt the brunt of patient care during COVID. So it decreases your patient load if you're not working in the COVID wards. So we were seeing less patients than the usual intern would, but the quality of care and the type of care that we were giving was different. So previously we would just go see patients without any masks, without any visors. Obviously, when we were doing procedures, we were still wearing gloves and using our normal infection control practices. But after COVID, it's become a lot more different. So now we have to be in full PPE all the time. We don't examine patients as much as we did before because we don't want unnecessary exposure. Patients we would previously resus or put a lot more effort into, we can't anymore because it's an unnecessary risk. We can't take the long histories that we used to before. We can't listen to that chest for that S3 for 3 hours. So our level of interaction with the patient has completely changed. Um, and it does feel like it has affected our internship in a way that is both positive and negative. It's definitely made us aware of infection control a lot more and taught us to be a bit safer, and also to be also taught us to take care of our health a lot more. But it's also decreased our time with the patient.
Sorry, Dr. Luke.
But I mean,
Sorry,
yes.
Dr. Luke, sorry to cut you in the middle. Just while we're on the topic of COVID, so we don't have to go back to this question each time, I just wanted to get all the doctors' perspectives on COVID and how it's affected your daily life and your practice and basically the impact overall. So after you're done talking about your experience with COVID, could we please have the other doctors' perspectives on that as well? Thanks.
Cool. I don't have much more to say. It's just that our experience with COVID is changing every day, depending on the patient number and how the system changes. So how our experience with COVID is still developing, and hopefully over time things will become clearer.
Hey, let me jump in here as a fellow intern. Um, so I just finished quarantine. I was in a COVID ward last week and I got tested twice because the first swab was invalid apparently. Thank you, AMPAS. And the second one came back negative, thankfully, so I'm going back to work tomorrow. So COVID has been a lot. It's completely changed the way that we do things at Barra. Everything has changed. Everything is new. Everything is changing every day. Like last weekend, like the plan for the weekend changed like 3 times within 1 hour. So it's very much about being adaptable. So COVID has made everything more difficult. Not everything more difficult, but the way I like to see patients is like, listening for an S3 for 3 hours. So I like to like writing long notes, really clocking a patient properly. And now that's not really possible because of IPC measures. So, I mean, when you're in PPE, you don't really have time to like take a thorough history. There's no such thing as a biopsychosocial assessment, which I like to do. So we've actually been told that like, just need to make sure the patient is fine from a medical point of view, and they need to go. Like, stroke patients have 3 days. If they're there for more than 3 days, that's a problem because you really want to keep on pushing people out. There's no time to like long management of patients because we are in, a crisis. So like the first pandemic we've had in our generation since like HIV, and it's shifted the paradigm completely in terms of what we can and cannot do. I mean, I remember at the beginning of the lockdown, there was a document about who gets into ICU, there was a statement that said that there was like a score about who would get resus, who wouldn't get resus. There was a thing that went out, like Ash said, that if you've been tubed and you have COVID, you will not get resus because that's how it's spread in Italy. And it's disheartening to an extent, but it's sort of what's necessary because we don't have infinite resources and we've never had infinite resources at Barra. There's always had to have been triage and trying to do the most and the best for the largest amount of people possible, which is difficult to keep in mind when it's your patient that's right in front of you and you can't do certain things because it won't be the most resource savvy way to do things. So yeah, that's my piece.
Okay, maybe.
Thank
Yeah.
you.
Can I jump in as well?
Yes.
All right. Okay. So thanks for the invite, guys, to the talk. Just on the issue of COVID, I think the two fellow colleagues have covered what I would say the direct impact of COVID. So for me, because I'm currently in orthopedics, so rarely our patient will come with shortness of breath. It's a broken bone. So we are experiencing the side effects. I would say side effects of COVID. So directly to our staffing, so there were colleagues who were actually in contact and had to go on quarantine, three of them, a senior MO and two of the interns. So we're left with two MOs and two consultants to run the department. So of course that significantly affects the staffing, and which means that the guys remaining behind, which I was one of them, had to sort of do double or triple times the work that had to be done, and actually it also delays patient care. So we run almost our theater every day, and because we had to cover theater as well as casualty, we literally were going to casualty like at 4. So patients would have come in the morning, wait there, hopefully they don't catch the COVID in casualty, for us to come and see them either admit or discharge. So definitely the patient care on that point, so these are non-COVID patients coming to hospital with unrelated issues because of the COVID impact and the regulations thereof. I think a lot of patient care has been compromised. And we also refer to Joburg Gen. We now can't refer a patient without a negative swab. All of our patients that we have tested randomly, so because we have to refer them to Joburg Gen, they've come positive and they're to be taken to the COVID ward for isolation. So it is really impacting on patient care on that regard. And actually, another interesting fact, maybe just due to the COVID, so the different levels of lockdown that we have experienced since level 5, casualty or trauma cases, let me say, they decreased. Of course, one can allude that to the banning of alcohol and stuff, and they will see it. The cases are actually on the rise now. The trauma is back, and yeah. So I think for me, that's much of what I can say. Beyond the direct impact, if let's say one, luckily I've not yet been in contact, I've not yet been in quarantine, but of course we treat everyone currently as a COVID patient. So every day we're wearing our full PPEs when we're going to theater. And I think also it impacts because even the theaters, they have to now allocate a specific COVID theater where every patient who's suspected goes and be operated in that particular theater. So I think for me, the side effects of COVID is what we are yet to deal with. When the vaccine actually comes through, which I believe is coming, we're going to be left with a lot of negligence, if I may say, to the non-COVID patients, because the attention, I think, has shifted mainly to the direct impacts of COVID, which is understandable. But yeah, for me, the side effects are the more dire consequences that we are going to face. Yeah, thanks, Lola. Sure.
I'll come in there. Thanks for having me this evening and for the interesting discussion that's occurring. My position is a little bit different to the colleagues that have just spoken. So I'm a COVID team leader, and I'm currently in COVID this week. We're looking after patients at the Helen Joseph Hospital. I've got a team of 27 people that I have to look after so that they can look after patients. Our hospital is currently full. We go on divert every day for 4 hours because we don't have space. And my biggest challenge has been keeping heads up so that we can actually get our junior staff and our staff and role switches happening. We don't go past 2 weeks. Every 2 weeks, something changes and shifts. So the mental health of a lot of our doctors is taking a bit of strain. However, we've developed excellent teamwork, and it's been great to do that across all of the tiers. We're just waiting for the other departments to join us, but they don't really have a choice in the upcoming weeks because COVID has absolutely arrived. It's a big challenge because rostering, we fix the roster every day. We had 2 registrars go down today. We've got 5 registrars off at the moment, and our team needs to be covered. And then at the same time, I have the unenviable task because I'm the undergrad chair of bringing medical students into the space at the same time and trying to make sure that we can train and prepare them to be interns in our teams. That's been an interesting challenge. And we've had a bit of a standoff with the university this week, which was fun. But we had a very serious discussion with the students today, and we were brutally honest with them. And we laid down the risk. And the biggest challenge that I find at the moment is not just managing the team and looking after people, it's looking after myself, but also helping people to navigate decision-making, because it's not just about working in a COVID area or are you at risk. The risk is there. It's about taking it home with you and how to mitigate that risk. What's been very interesting is doctors are still lay people, and they forget when they leave the hospital. In fact, for me, the safest place at the moment is the hospital because people do everything properly. It's when they leave that it's a bit of a challenge. I mean, most of our COVID outbreaks among staff were attributed to 2 or 3 gatherings. One was a braai, the other one was a wedding, and the third one was an Acha festival. I didn't even know, but that knocked out 48 nurses at my hospital. So it's been quite a challenge, and learning again how to do this and be a physician in this space and practice high quality medicine has been an incredible challenge. Like Dr. Sibanda mentioned, you can't examine patients properly. There's a lot of diagnostic blindness. Everything's COVID and you forget about everything else. We nearly had a young DKA die today because of that, which would have been a travesty. So yeah, it's been an incredibly interesting space. And I find that we're flying an aeroplane that we don't know how to fly, and we're building it while we fly it. So that's the best description I can give of our current COVID response. That's my input.
Okay, hi everyone. Thanks for the opportunity to speak. My name is Dr. Farouk Mamdoo. I'm a practicing cardiologist. I work in one of the busy acute coronary centers in Johannesburg. And I'm also with the Wits Department of Physiology and lecturing there, and still do a little bit of help out at Johannesburg and Johannesburg Hospital, as well as BERA for all the sort of structural complex heart diseases. The COVID response in the private sector is surged, I think, at least a couple of weeks earlier than the public space. The problem has been, of course, in my line of work, everything's acute coronary syndromes, and there's really very little time for triage of patients, and the diagnosis is usually very easy or very obvious from the start. So COVID has changed practice a lot in the sense of the way we prepare patients and the way we decant them after they've had their acute coronary work. It's obviously very difficult wearing all the gear. I mean, you must understand we work in a cardiac catheterization laboratory, so there's lead aprons as well, plus the COVID gear, which makes it very warm and very hot and uncomfortable, and sometimes even difficult to see looking at a fine coronary image on a fluoroscopy screen. But what's happened in the private space, at least, I think from a resource point of view, the biggest challenge has been nursing staff, where we have to change shifts and keep the staff separate. Normally we have quite a big team around us when we work, so the patient throughput is very rapid. But having to split the teams so they don't cross-contaminate each other has been a big challenge. So often the nurses have to work very long shifts and they're short on the ground, and then they have to rotate, which isn't very conducive to throughput from a hospital point of view. Also, what's also challenging in the COVID space is also deciding. We've had so far, I think, about 3 or 4 patients with massive acute myocardial infarctions, but they also happen to be COVID positive. Not COVID related, but COVID positive. And the decision whether or not to even resuscitate these patients once they get intubated is now becoming quite a challenge. Obviously, as you know, their prognosis is poor with comorbid disease. A lot of these patients are diabetic and hypertensive, and their outcomes are generally poor. So there's no real guidelines from the Health Professions Council or for anyone. We don't have answers on which patients need to be, you need to go all out and which patients should actually be palliated. It's very difficult. And in the private space, you literally have only yourself to rely on in terms of making those decisions with the family. Often we're unfortunate enough to have a lot of academic colleagues, both locally and abroad. So we often share information and making decisions together. But again, it's very difficult. I think what's going to happen as well now is we've seen it is the patients are also being afraid to come into hospital. So they're not presenting early enough. And someone with heart failure, an acute coronary syndrome, time is muscle, and they're coming in later, which leads to further complications and prolonged stays in hospital. And again, there's always a competition for bed space, and acute bed space is even more of a scarce resource. So often there are clashes about patients arriving in ED with COVID-related problems and acute cardiac problems, and there's usually just 1 or 2 beds left, and then the decision on who to triage, which patients to divert to other facilities is often based on wherever facility is available. So we're currently doing strange things like patients coming directly with an ambulance or even on walk-in patients with an acute coronary syndrome. They go to our cath lab, they go back into the ambulance and circle around the block for a couple of hours until a bed can be made available for them and a patient can be transferred around. So I at least with these sort of resources in the public space, sometimes those kind of things are a little bit more possible. But in the public space, of course, having the luxury of someone waiting in an ambulance on a monitor is not always available. So I see that we're heading for a lot of trouble. And we need volunteers. But that's from my side.
Thank you so much, doctors. We're just going to go back to Dr. Sibanda to talk a bit more on internship, and then we'll continue from there.
Okay, there we go. Let me just find my questions. Sorry. Okay, so my first question was, how is the transition from medical school to internship? And advice for a smooth transition. So the transition from medical school to internship was, well, I am at Barra at the moment. I didn't want to go to Barra, but I was sent there because that's how things happen like that sometimes. So it was kind of like going from 6th year to 7th year. It was because I did most of my rotations last year at Barra. So, I mean, I knew how Barra was from a student's perspective, then sort of started learning what it's like working as an intern. It was basically like having a new year at school because a lot of the people who were in my class in 6th year were interns at Barra this year. So it was a smooth transition, I would say, but it was also scary because I started in peds and I started in peds casualty, POPD. So on the first day, the consultant told us basically you are the front line. So when the kid comes in fitting from clinic, it's up to you to save this child's life. And after like 10 o'clock, it's basically the 2 interns or an MO and an intern. So you had to like step up and become competent quite quickly because you are basically the first person that this dying child is going to be seen by. So from that perspective, it was quite scary, but it was also quite empowering because after like 6 years of like always being on the sidelines, always sort of watching the action from the side, now it's up to you to use all the knowledge and all the skills that you've gained up to that point to act and save a life. And the best advice I can give for a smooth transition is, if you have passed medical school, you know enough to be an intern. So from that perspective, try not to worry too much about what you don't know, because by being confronted by all these different kinds of patients, whether you're familiar with the pathology or not, you will become competent. So revel in the opportunity that you have to practice medicine, because it is a privilege and it can be incredibly rewarding. And the great thing about being an intern is that while it is up to you to a certain point, you're never alone. There's always your fellow interns. There's always an MO. There's always a reg. There's always a consultant. And they might not always be there physically with you, like when you were a student, but they're always a phone call away. They're always a shout away. Like when I scream resus, all of Barham is hearing me scream resus, because the first thing they always tell you when you're in a resus situation is call for help. And the great thing about Barra is you always have someone that you can call. So, okay, then did you feel medical prepared you and equipped you well enough? From a theoretical point of view, yes, but from a practical point of view, not so much. Yes, there's certain things that students really shouldn't be doing, like putting in central lines and doing amputations. But I feel like this was very much focused on theory. The main thing that you had to do to get through medical school was be grounded in a theoretical. I had to have a strong theoretical knowledge. Whereas I feel like at other universities, there's a bit more focus on practical skills. I'm not saying I feel like I didn't have enough practical skills to be an intern, but I kind of wish that I had more going in. Internship is a great place to learn practical skills, but I kind of wish that I had a bit more, because it was very much luck of the draw in terms of whether you were exposed to certain procedures. For example, chest drains. I still can't put in a chest drain. I can rattle off the theory quite well, know where to go, what instruments to use, blah, 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 blah. But it's different to actually doing it. And now with COVID, I just finished surgery. I was doing trauma calls, but we weren't allowed to put in chest drains, which is a shame, because, if you're Barra, what are you there to learn if not putting in a chest drain? And then how does placement work? I think Ash pretty much said it all. I don't think where you go as an intern impacts your specialization journey. Like, I want to be a surgeon, but I don't think that being at Barra has particularly helped or hindered my aspirations, because there's so much time to learn. I've done operations, I've learned how to put in central lines, but I feel like that's icing on the cake almost, because I feel like internship is more about learning. I don't want to say how to be a doctor, but how to work more independently and how to make decisions by yourself while still having some modicum of supervision. I think that what more influences your specialization is where you do community service, where you go work as an MO, because, for example, with surgery, which is what I want to do, like ComServe and MO time is the time to learn how to cut. It's the time to do ATLS. It's the time to become competent in theater. Whereas internship is sort of like, if you operate, that's fantastic, that's lovely, but that's not the main focus. I feel like the skills that I'm learning right now are, one, how to be organized, how to make things happen in your reg, when a patient is bleeding out and your reg asks for like a 441, but the patient doesn't have a GT number, like how to get around that, how to make the clerk print the thing quickly so you can go order blood and stuff like that. And honestly, I had bad luck with placement because I didn't want to come to Barra. I was sent here by force. I initially wanted to go to Cape Town, but the government was like, no, you're going to Barra, period. And what things to consider when applying for internship placement? I guess what kind of lifestyle you're willing to have. So the Barra lifestyle is very much you go to Barra and that's it. That is your life. That is the main thing that's going on, and you live, you breathe, you sleep, you eat Barra. And it's incredibly demanding because Barra interns are put through a lot. You're expected to just make things happen, and you're expected to make a lot of things happen for a lot of patients, and to make sure that things are done well for each and every patient, which can be incredibly difficult and at times stressful because you have so many patients. And yes, you're part of a team, but even within that team, you're still taking care of like massive amounts of patients. When I did surgery, I was in acute care surgery, and at any given time, we had between 30 and 60 patients. And that was just the standard of care. That was just the standard. And I say between 30 and 60 because we never really knew how many we had, because we basically admitted every single acute surgical patient there was. And that means you do their bloods, you put up their drips, you discharge them. And, you know, discharge takes time, and you need to like sort of develop a system, make sure the TTO goes the correct time, otherwise the patient just will not go, you know, stuff like that. And then things to consider, yeah, so you need to decide what kind of lifestyle you want, because if you don't want to like be, and it's like a trade-off. I mean, you can be really, really busy, then you get out of it really good time management skills, and hopefully post-COVID, a lot of like practical skills, or you can have fewer patients, you don't get to do as much, but you're not like at the hospital until 8 at night pushing a patient who's going to die the next day. But you know, you get, yeah. And at Barra, you're everything. You are a doctor, you're a phlebotomist, you're a porter. Sometimes you do basically everything that's possible for a patient, and you just have to make things work, because you know the system sometimes doesn't make things happen for your patients. So you have to, everyone sort of chips in and makes things happen. You know, like I've seen registrars who are nearly consultants like taking bloods because there are 1 million bloods and it's necessary for the patient. So you know, we all have to, you know, chip in and make it work. And it can be difficult, can be frustrating, can be tiresome, but if you're willing to put in that much work, then Barra could be the place for you. But if not, I think rather go to a smaller hospital, because Barra is very much its own animal, where it's like there's 1 million patients, it's always falling apart at sometimes, but somehow it still works. So yeah.
Lola, are you there? Can I come in, Lola?
Yes, Dr. Muhango, you can speak.
All right. Yeah, once again, thanks guys for the invite. As introduced, my name is Leonard Muhango, and I'm currently doing my community service at Far Eastern Hospital in Springs. You know, so my first question was to give my overall experience, you know, as an intern. So I think overall, I would say, so I did my internship in Ladysmith Provincial Hospital in that's central KZN, rural part of KZN. You know, it's a regional hospital. So my overall experience actually was quite an interesting one. And I also did not apply for Ladysmith, but I was placed there. You know, and if I had to be asked to apply, I think I would have actually chosen Ladysmith. So I just maybe listening to the colleagues, I'll just group my experience, you know, under categories. So one is supervision, work environment, social life, and yeah, those three. I think I'll cover most in that. So Firstly, I think so. As colleagues have said, there's definitely obvious differences in the supervision. This is in terms of availability or physical presence of a senior person, to oversee. So just to make a point or a note, all accredited facilities for internship, they are accredited based on the availability of supervision. I think that's the number one thing that they look at amongst many other things. So then to compare, so when you are in the rural areas or where I used to do my internship, you are sort of put in the deep end, the so-called you put in the deep end for you to swim along, which one can look it as a bad, but I took it as a good experience, because I think what it definitely did was um, I was able then to, as colleagues have said, when you leave med school, I think you have got enough information and knowledge. You might not necessarily have the practical skills to sort of manage patients, in a casual setting, but being left there to manage patients there, it sort of gives you that confidence. So one thing that I definitely give a thumbs up for at least doing my internship in a rural setting was the build up of skills, and being able to actually manage patients fully, like from presentation to discharge, if I may say, So just an example would say, if let's say it was I had colleagues speaking about surgery, let's say in a surgery call, step abdomen comes in, I'll be on call. So with us, maybe actually we're fortunate because actually either sometimes on call as an intern with the consultant without the MO, because sometimes it's short staff or whatever the case may be. So what it means is step abdomen comes in, I prepare the patient, call the consultant, we all go to theater, and then you are sort of taught and actually allowed to sort of participate practically. Whereas, as I would have witnessed in the academic settings, in para, I did my surgery at para. In the surgery repeat, as an intern, you clerk the patient, present to junior reg maybe present to senior reg calls consultant, and then ultimately is the consultant maybe and the senior reg who goes to theater for the particular operation, for the patient, which leaves the intern just would have done the sort of the prepping part, and you are sort of then left to manage the patient after the op in the ward, in a ward round. So I think my internship was more practical. I did both, so we had to prepare and actually be involved. So I think that's for me number one. Supervision was adequate. Of course, no access to registrars, but we had the senior MOs with the experience. We had the consultants. Again, as I said, they are all in a phone call away, and they might not necessarily be physically present on the facility, but definitely a phone call away in case of emergency or when you need the help. And another thing I think is the way. So with the work environment, you know, um, of course, you see the academic circuits. I think this is common every regardless, not necessarily our vet circuit. Every academic circuit, I think it's the same thing. Where there's this, the hierarchical structures. Whereby of course there's intimidation, or I don't know if that's bullying, whatever you call it. Where this senior, whoever senior is there. If let's say as an intern you miss or you forget for whatever reason, maybe you're busy at a busy call, you forget to pull out the results of a patient, then they sort of go harsh on you to say clearly you don't know what to do, and all sorts of things are said in what rounds. So I think for me that I didn't even experience. I was shocked, to find that actually you can get to a hospital where the consultant actually does a what round with you, actually pulls bloods for you and say, you know what, no, you fill in the X-ray form, I'll pull the bloods, or I'll put up the drip. So for me, I think the working environment, it was completely different from what I had experienced as a student in the academic circuit, where the consultants and the profs, man, there are people you don't just walk up to prof or consultant. You must first go through your MO, your intern goes to junior reg goes to, until it's only the senior regs who actually have access to the consultant. So as a mere intern, they will see the other colleagues, they don't have that luxury to actually easily chat with the consultant on the prof, not necessarily on a personal level, but just as a colleague, to say we are both in this medical field. I can speak to the prof or the consultant as a colleague and ask or whatever it is. So I think for me, that was the biggest thing that I sort of enjoyed, the maybe that you are able to work with consultants. They treated you like colleagues. Then really the hierarchy wasn't there. It was all like a flat type of a system whereby everyone does everything. And of course, again, being in rural, it was regional hospital, fairly busy. But unlike the para colleagues there, we got our free weekends now and again. And the rural life is so nice because even the other allied healthcare workers. So because it's a small town, you almost know everyone. So it's nice that the whole idea of a multidisciplinary team actually materializes. I actually saw it to fruition, and you get to know who's the OT, who's the physio, what are they going to do, who's the dietitian, but in the academic circuit, the only people that you knew were our colleagues and students, but I hardly saw that multidisciplinary team, together, because of I think I'm sure the hierarchy or just the split, how things are so much compartmentalized into different departments, and regions. So yeah, I think for me, overall internship was great. I really enjoyed working in the rural areas, and I would encourage the students who will be watching, because I know that applications are open. Do consider, and of course, there's mentioned there are a lot of reasons why one will choose a place for internship. And if you have no obligations whatsoever to remain in the academic circuit, I'll challenge you to say, go to a rural place. And another thing actually is because I think, after when I left med school, I was sure about one thing, that I'm going to specialize. And I think that's the common feeling about amongst all of ourselves, all of us who live vet medical school to be specific, is that they sort of push us to a point where you feel like, specializing this is what it takes to, and taking yourself out of an academic setting into a rural area or a place where, like, a non-academic environment, I think it also allows you to appreciate, or to at least see, the deficiencies in the public healthcare sector, if I may put it like that. And then just appreciate, so that at least you can be able to contribute one way or another, either to be, when I left med school, I wanted to do orthopedics as a specialty, did my internship, and I'm slowly wanting to do family medicine now, because I feel like there's a lot to be done in primary healthcare, because of the exposure that I got in internship, and how I feel like there's more need for us to be in that particular sphere. So I will actually encourage other colleagues to consider rural health, especially if we have no obligations to be in the cities. Don't leave one academic setting to another. I think it's still the same. So even if you go to the UK certain setting, the still same setup. I've got colleagues who are there. They're still complaining that, what, we live late, you come early, consultant, they are harsh on you, and it's just a bad day. So I really think you might need a change of scenario, at least for the 2 years, and then of course you can easily come back to the circuit for whatever reason. And I'm glad that the two interns who are at Bara did say that there is no advantage whatsoever to say, if I do my internship at Bara, therefore I'm likely to come back and be a reg, because I would have known the profs or the whoever it is. I don't think internship really has an advantage in terms of where you do it for specializing. Yes, you will know, okay, that, okay, if let's say I do it Simja, you know that, okay, Prof Luvengo is the head of surgery, and you can maybe chat with him in the 3 months that you have to say, Prof, I want to do surgery when I come back. But that's all really, so there's really no advantage in where you do internship. So that's why I think it's more important than to go out and they'll say, get your hands dirty. I think for me, internship is reflecting. It's a period where you need to actually gain the practical skills to be able to make a confident decision and manage a patient. Yeah. So I think that's that for me. Uh, on my experience on internship. To go on to my second question, which was, what's the difference between ComServe and internship? So the biggest difference which I've seen, I started my ComServe, actually, this is my second month as a ComServe. So, but the biggest difference is the responsibility. I think for me that's the biggest jump. From being a intern who is a junior, always knowing that, okay, I always write, admit this patient on this following management plan, discussed with a senior. Now it's at the point whereby you are that senior, there's an intern who calls you to say, I'm discussing this patient for admission. So you are sort of, there's now a bigger responsibility in terms of patient care, and the load is expected on you. So I think for me that's the biggest difference. And again, I think another thing is, because I come from an environment where I was already hands-on, so I don't have any like fear or anxiety when managing patient or when confronted with patient in an acute setting. So it sort of allows me to easily work or assess or help the interns in the case that the ones who be rotating through orthopedics. I said I'm doing my concept currently 6 months of orthopedics. That's where I'm in. So yeah, for me that's the biggest difference really in internship. And I think if let's say again, because talking about the differences in terms of peripheral doing internship in the peripheries and in the academic setting, the jump would be again, as I say. So there are other colleagues who were in the academic sector and they've been placed, for example, at a district hospital. I'm at a regional hospital. I'm lucky. I'm still working within a department. But the colleagues who are at district hospitals today, you might be in. There's no departments. There's just male, female medical ward, male, female surgical ward, ops and gynae. And I think that's much it. So today you might be the ops and gynae doctor. Tomorrow they might say, please go do the surgical wards. So we are almost everywhere. And as such, it requires more for you to be a whole-rounded person actually, and who's actually hands-on, who knows how to do the procedure. Someone mentioned chest drains and stuff. So you must be able to do those procedures because you are basically placed where there is a need. And I think that's what community service is about. They basically place you where there is a need, within the particular hospital. If it's a regional, luckily you'll be in a department. And sometimes I think just going into another question to say, how does placement works? So I think it's pretty much the same in terms of application as internship. Same options, 5, but it's more of, there's fewer urban options, if I may put it like that. It's more because ComServe, I think, was designed to provide healthcare in the periphery. So there's more places in the periphery. So chances of you ending up in the peripheries are very high. Of course, Simcha still has ComServe. I think even Bara still get ComServe. In the sort of the academic circle, they still get, but they get them. The number is less, compared to how many interns they get for that particular facility. So chances of you going to a peripheral hospital are very high. So you should then be able to be prepared, to say, if I'm placed in the Pundus, at least you'll be able to manage a TKA. You should be able to stabilize a step chest and put up a chest drain. Should be able to do the basics, basically to save a patient's life in an acute settings. So I think that's for me the difference there, in between ComServe and internship. And then my last question was, how does ComServe helps your potential to specialize? So as I said, so if let's say you are placed here, at least there's a difference. At least if you are placed, let's say, in a regional hospital, if let's say one has got an interest in anesthesia, for example, and they're placed in a department where you are allowed to do anesthesia at least for a year or for the 6 months, whatever duration you have to do it. Some hospitals or some facilities, they sort of have got that accreditation that you can actually do certain diplomas, which might make you apply for a particular specialty. So I think then, but it's unfortunate, as I said, that when you apply to a hospital. Of course, you will have done the background check, where Far East, and I choose Far East, and then if I go there, if luckily if they place me in anesthesia, I might get the chance to write the diploma in anesthesia, for example, which might help me when I apply for a reg post in anesthesia in academic circuit. But as I said, that because ComServe, basically we are placed where there's a need. So you might apply to Far East, but you find out actually they don't need ComServe in anesthesia. They need ComServe in psych, for example, and you end up being in psych, where you don't want to do psych. So it's I think it should be then wise for you just do a background check and then literally find out where ComServe are needed, and if that particular place sort of has got the particular specialty or the department in which you want to go in. So if you want to do internal medicine, then if you check a hospital or a facility that has got great internal medicine department, we can do your ComServe there, and you'll be able to sort of start already, preparing for if there's primaries there or whatever the case may be. So I think that way it sort of pushes you a step further or step closer towards specializing in your interested field, provided you are placed in that particular field. It all depends on what the hospital needs and what the medical managers of that hospital is. But for us, we're given the option to actually say choose wherever I want to go, out of the departments which are there, and then colleagues went according to where they wanted to be. So I think that's me with my questions, and I'm not sure. We said we will leave the last question for last, the one of what would have done different in medical school. I think that's the
yes, we're gonna leave that for the end. Thank you very much, Dr. Muhango.
Sure.
I think I'm going to come in there and just get through a couple of the questions. So my name is Dr. Tina Ingratta. I'm head of unit at Helen Joseph Hospital. My primary speciality is a general physician because I couldn't figure out what I wanted to specialize in. I carved my own path. And so I'm also specialized in medical education. I'm one of the only people in the university that has that degree attached. It was a bit of a challenge to do, but it is definitely my niche. And I do love teaching doctors, undergrads, all the way through. How did I choose internal medicine? I didn't. I took a very roundabout route through internship and ComServe. In ComServe, the only supervised rotation was psychiatry. So I decided I needed a degree because I was in the middle of nowhere in Mpumalanga province. And I went a little bit crazy myself. So my colleague and I decided to do the diploma in mental health. And then I thought, let me give it a bash. So I went and did Barra psychiatry. And I learned in psychiatry that I was more of a physician than a psychiatrist because I kept trying to treat everyone's hypertension and diabetes. So from there, I jumped straight into internal medicine, but I had to do medical officer time first because you can't get into most training circuits without doing MO time in the field. So I did a year as an MO. I did ICU first and then pulmonology, and then I jumped into the registrar circuit. So internal medicine, I absolutely love it. It's a clinical problem-solving space. We figure things out. We treat things with medication, and then there's an opportunity to subspecialize. It's quite a journey because you have to do 6 years of medical school, 2 years internship, 1 year ComServe, a variety of years as a medical officer determined by what your journey is. And I do highly suggest that after ComServe, you don't feel the need to specialize. It's quite a lot of pressure to step onto a specialty ladder. And it's actually so liberating to just do 6 months in whatever field you want. Go overseas, stop doing medicine, go and work for a pharmaceutical company. I don't care. The point is, once you're in a reg program, it's quite difficult to pull yourself out because doctors, by their very nature, like to start what they finish and finish what they start. So give yourself an opportunity to explore in that time. It's difficult to do internship and community service overseas. In fact, it's quite difficult to do from South Africa. So only after ComServe do you have the opportunity to go overseas. On that note, your logbooks are incredibly important. That's the only reason they want all that detail that you painstakingly fill out. Nobody cares except for overseas universities. So make sure you fill out the detail quite explicitly because it is your ticket to overseas. How does internship influence specialization? It doesn't. It'll either beat out of you something that you love or introduce you to something that you didn't think you would like. And often internship puts you off a speciality more than gears you towards it. Community service often is the place that helps you decide what you're really built for. The specialization programs, how you get into them is tricky because you've had to have done 10 years as a student and then a doctor. And most of them have a lot of requirements to get in. So once you've decided what you want to do, you need to look that up. And the best place to start is at the facility you want to train at and chat to the heads of departments there and figure out how to get in. What's the quick way to get in? And the postgraduate committees in all of the specialty departments have that information for you. And often it's additional courses and things or time in certain areas. And if you really are sure about what you want to do, find that out early and get on with it so that you can get on with your specialization if that is your thing. Most programs are 4 years. The intensity of the program is determined by what field you choose. The very heavy fields are particularly in order. Surgery and medicine are about the same. Pediatrics, they're all incredibly difficult and heavy on you. Anything else is a stepping stone. So you can't jump straight into urology without doing surgery. Orthopedics is its own thing, and it's quite intense. But if you love hammering nails, then you'll know at the beginning. Personal experience, life as a registrar is worst life you could have. how your colleague described Barra, that's what registrar is like, but it's for 4 years. You work, you breathe your space, and you're expected to submit some kind of research project, and you're expected to have a life, possibly have children and have a family. It went by in a blink, and I barely remember it because it was quite intense. I was incredibly happy to complete my registrar time and become a consultant, and that brought with it a whole bunch of other challenges. But the one thing that I want to say is, and vehemently push for this, is there's no rush. And that ladder is very well described. Everybody, it's like an algorithm. You know, you go to medical school, you go to internship and ComServe, and then they're like, what are you going to do now? And everybody assumes it's a speciality. It can be so many things. You can step off and go and become a general practitioner. And a lot of people love that and live for that. And those doctors are wonderful and you need them. If you choose to specialize, do not feel pressure to pick anything in particular. And also, if you're in a program and you don't like it, please change your mind and leave. I've had a colleague, she spent 6 years in a specialty program, and only before she wrote her final exam did she decide she hates it. But she hated it all along. So she took 6, 7 years of her life, didn't complete it, and now is back in a registrar training program. And that's fine. I mean, that is her journey. But it was grueling because she felt like she had to finish, because that is the nature of the beast and our personalities. But I'm saying carve your own pathway. And that's what I did. It was incredibly difficult. I sat in an interview for a fellowship position, which is a subspecialty position. And in the meeting, I decided I didn't want the job. I was the only candidate. It was quite embarrassing. I was a bit of a shoe-in. But I decided, you know what, I don't want to do that. So I just did general medicine, which is also a little bit of an anomaly in academic spaces. Everybody's a subspecialist. And general medicine was wonderful for me because it helped me discover that I love to teach. And then I went and found out about how to do that and how to do that well. And then now I'm involved in developing the WITS curriculum, and I love it. And I'm designed to do it. And I also practice full-time as a clinician. So both of them feed into each other and work both ways. So I'm an example of someone who stepped off the algorithm, and it was the best thing I could have done. That's enough from me. Thank you.
Thank you, Dr. Ingratta. And finally, we're going to hear from Dr. Mamdoo.
Hi, everyone. Once again, I'm Dr. Farouk Mamdoo. I'm a cardiologist in private practice, but I'm also attached to the university with the UMI and the Department of Physiology. And I still do a lot of honorary consultant work for Baragwanath Hospital as well as Johannesburg Hospital, and also involved in the teaching and the academic curriculum for the GMP 1 and 2 students. So the questions I was asked is, why did I want to do cardiology? The real answer is it was unlike what we've heard before. I always wanted to do cardiology. I guess I sort of fell in love with the subject because when we started off at medical school, if you guys remember physiology and physics in first year and second year, I sort of loved the mathematical intricacies of working out flow dynamics and mechanics and so forth. In fact, before I got into medical school, one of my second choices was engineering. So I guess I came from that background, and mathematics was my thing at school, a bit of a nerd in terms of mathematics. So I think I fell in love with the idea of physics and rheology. And of course, cardiology is very much to do with that. So it was always cardiology. I think I realized I wanted to do cardiology when I was in medical school. And then, of course, I guess I was one of those that was fortunate enough to fall into that space. It's quite a long road to become a cardiologist. It's from the internal medicine point of view, it's one of the longest specialities. So you have to, once you've completed your internship and community service, you have to do 4 years of internal medicine, qualify as a physician, and then get into the cardiology training program, which is usually 3 years. So most other subspecialties are 2 years after internal medicine, for example, pulmonology or rheumatology and so forth, but cardiology is a little bit longer. The reality for that is because there's a lot of operative skill and on-hand experience, which you can't gain just with theoretical knowledge. There's a lot of experience that comes with the training. And I think it's also a little bit of a sort of hybrid speciality. One of the reasons I liked it, because there's a lot of operative opportunities. We go to theater, we go to the cath lab, a lot of surgical skills come into that. And I think that's why a lot of the training is built into that. So it takes a little bit longer to gain that sort of expertise. And of course, the theoretical knowledge that comes with that also is quite extensive. How did it work with me? I was also at Barras for my internship. I went off to Standerton for my community service. We were the only second group to have to do community service at that time. And it was great. As Dr. Muhango said, it was great to get off the ladder. I knew I wanted to do cardiology. I knew I wanted to come back, but I really enjoyed hammering nails, doing cesarean sections, and all sorts of things at the peripheral hospital that I was in. And it also hones your skill. There's a lot of guts you need to develop when you specialize, and I think the comm service and Barra internship gave me that sort of guts and confidence. But it's really about developing your confidence level. It's also something that you need to be aware of. If you know you're in for a long road, you don't allow yourself to get tired and freak out too early. You just got to keep on going. So if you know you're in for the long haul, specializing and it's a long speciality, you make the best of your situation wherever you are. And of course, you try to do the best at that every single time. So that helped. And then when I got into the program, of course, at Para Cardiology, there was a lot of work. I was unfortunate enough to have almost every other fellow and junior cardiologist leave the department at the time, off to greener pastures. So for about 2 years, I was the only trainee cardiologist. So a qualified physician, but the only trainee, or what we call fellow cardiologist in the department, which I was lucky enough to be supported by people like Dr. Ingratta, who were physicians or trainee registrars at the time. So they would help me with a lot of the workload that I was obviously entrusted with solely at that time. So yes, once I qualified, it was a matter of my goal was to stay at Barra my whole life. Research, serve the community, not do anything with private practice. But unfortunately, not only do I like kids, I like making kids, and I have to feed them. So that's where private practice came in. And it was more of a hobby. It was actually a side gig for me, just to have a little bit of extra income. It was definitely not a plan to build a practice or become an empire, so to speak. But it literally was just supposed to supplement my income so I could afford to send my kids to better schooling and so forth. My wife's a pharmacist, and she's no longer working or practicing, and she wanted to stay at home longer once the kids had grown up. Her plan is still to go back, but I wanted to support that. She preferred to be a stay-at-home mom, and that means I had to be a stay-out-of-home dad in order to support the family. So that's where the private practice started coming. But also what sort of allured me more and more into the private space is, unfortunately, cardiology is one of those specialties where you're very heavily reliant on high-tech equipment, and that sort of equipment started becoming more and more lacking in the public sector. And it became more and more frustrating, more and more limiting to not be able to do the things you want and the things you love. And that's when I realized also the opportunities in terms of advancing the career, advancing my training, advancing my skill level was sort of blossoming more in the private space rather than the public space. So with that came obviously a lot of challenges. Initially, I tried really hard to balance them, to spend as little time as possible in the private sector and just to sort of hone skills. But running a private practice as well as staying in the academic as well as public sector became very difficult. And as you know, remuneration and call rosters and RWAPS legislation became very difficult to balance. Also, what I realized I was doing also for a lot of the time was I was blocking a full-time consultant's post in the public sector, which obviously wasn't allowing new guys in. So we tried for quite a long time to sort of advance that or change that to change it to a sessional post, but unfortunately, administratively, it wasn't really possible. And that's sort of where things kind of fell apart and I had to part ways. But I still try and keep in touch with the guys, and they do ask me to come in quite often to help with more complex things. I still do a lot of training, both in the private and public space. But the goal would be obviously to come back to a fully fledged public sector that paid me better so I could look after my kids and still do all the things I love to do. So the typical day in the life, I'm still in my rooms. I still have a ward round to do. I have about 4 new patients that I haven't even seen that have come in. Not acutes, thank goodness, but patients I still have to see. So my day starts off at about, I get to the hospital I work in at about 7:30 on average. I'm getting there a little bit earlier because I can't go to the gym anymore. I used to go to the gym first and then rock up at work. But now I'm getting here early because the gym is closed and all I can do is run around my yard to keep fit. So I get here a little bit early. I usually start with the ward round, generally in the ICU and then in the wards. And then I get up to my rooms, usually about 9:30. I start seeing patients in my rooms. I usually finish in my rooms about 6 or so in the evening. And then usually during the day, there's a few more patients that have been admitted or I want to check up on, or patients that I think are a bit more sick and I want to give a second glance to. So I'll go back and do a ward round on them again. And of course, in between, if I'm on call, often we have to run out and go and do an acute coronary syndrome and go to the cath lab. I managed to balance my days a little bit. We have the days I'm in theater and the day I'm on call are separate days, so I don't book patients in my room. So I'm dedicated just to that, so we don't have people waiting in your waiting rooms while you're running out. But inevitably, you have to do that every once in a while. From a reward point of view, the reason that I love cardiology is because it's one of those specialities where you can tell the outcome quite quickly. And even though it may look dismal in the beginning, the patients are desperately ill, you can do a lot to bring them out of that with adequate, obviously, training, experience, and equipment. And it's very rewarding to see someone who looks like they're on death's door to turn the corner so quickly as well. So you get that reward and that sensation quite early on. A lot of other specialties obviously are very rewarding, but generally you see that outcome a little bit later, a few days or weeks later, whereas a lot of things with cardiology are very quick. So it's I'm a bit of an adrenaline junkie, I would say. So I get my fix early and I get my reward early, which is just built into, I guess, a part of my personality, which is why I like it. But at the end of the day, it's a very rewarding specialty in terms of private side. It can be also quite well remunerated, but it does take a lot of your time. I think in terms of a family life, it's very demanding. You can almost never switch your phone off. Your patients can complicate at any time, whether you're on call, whether you're not on call, they'll find a way to get hold of you, whether in another hospital, whether in your hospital or at home, they'll find a way to get hold of you. And it's quite important to be able to provide patients and other doctors with feedback on your patients, especially when they arrive. So it's a constant calling. It's not something you can just switch off from most of the time. And but it also is very rewarding. Patients develop a long-term relationship with you, which is also nice because once you're sort of you got their blood on your hands or your fingerprints on them, so to speak, they come back to you. And they're also very grateful for your input because you change their outcome so acutely in their most desperate need, in their most desperate hour. You were the face and you were the hand that brought them out of that. They almost always are very grateful and remember you forever. So they tend to follow you forever and you develop a long-term relationship with them as well, which is also very rewarding. So from my side, I wouldn't change anything. If I'd gone back to medical school, maybe I would have paid a bit more attention to some of the other disciplines because every now and then you have to interact with that. But I was always quite focused and I was always quite keen on doing cardiology, and I was also very lucky to fall into the disciplines and get posts and so on early enough and not have to wait too long, so to speak. But that was my aim, and I would have totally enjoyed being anywhere else. If I had to wait longer in another discipline or do an MO job somewhere else, I would have happily stayed there until a post was available to me. Because I guess at the end of the day, wherever you are, if you've got a goal, if you've got an aim, no matter how long it takes you to get there, it may be frustrating at times, but you'll make the best of it. And I think that's where you don't know you're heading. I mean, you might end up with a virology coronial bunch of medical school graduates that know everything there is to know about epidemiology and virology. It's just because of what we're exposed to today. In my time, it was HIV, actually. We were, I think, the first few group of interns where we had no access to ARVs. It was a very depressing time. And we would do sort of all sorts of funny procedures on patients in the absence of ARVs. So in a way, we got used to trying to take care of ourselves and look after ourselves. There was no such thing as personal protective equipment. It was literally a glove that you could hopefully double glove if you're lucky enough to have that. And we were exposed to TB and HIV running rampant in the wards. But again, we adapted. And I think the group of people that are coming out today and the interns and medical officers that are out there today are also learning to adapt. And I think that's very important for anyone going out of medical schools. And medical school is relatively rigid. You've got your timetable, you've got your learning objectives, you've got your exams. Everything is very sorted out for you. It's very structured. But once you hit your internship and community service, you need to adapt. You need to wing it a lot of the time. You need to ad hoc it a lot of the time, but you also have a lot of support around you, which is very important. Most people are in exactly the same boat as you and went through it as well as you, and they're very supportive of that. Make good friends with the people around you, develop good relationships with your colleagues, do them favors, take on calls, help them with their drips, do their blood transfusions, go pick up their plasmapheresis and all sorts of things that you can help them with, and the reward will come back to you. So that's from my side.
Thank you so much, Dr. Mamdoo. So just before we have a few questions, I'd just like to pose our final question to the panel, which is just the advice that you would give yourself if you were in medical school. I know Dr. Mamdoo has just answered that, but if we could have just a brief sentence or two about any advice you would give your medical school self.
Okay, I'll go. I would tell myself to party more, have more fun, spend less time on up-to-date, and go out more. That's what I'll tell myself, because being a bar intern, there's really, and the lockdown is like you sit at home or you're at work. So I'll just tell myself to enjoy the time at university more.
Okay, I'll go next. So I think the advice I'll give to me in med school, I think will be, as Dr. Mamdoo has said there, to say we're already in a structured program. I think what I would have done is actually step out of the structured program and sort of go, like I know there is a program to go to the clinics, but it's also structured. It's sort of something which is more like an elective on a fortnight basis, so to speak. Randomly go to the parapet, and get involved at that particular time while it's still at med school, so that so as to get the experience, of what really it means to manage a patient, outside having to go through a tallies, the history exam, step by step thing of doing things. I think that's number one. And number two would be to more. I'm not sure if this is then I think there is a bit of it, but the managerial part of medicine or in the medical field, I think that is something that I wish I was more inclined to, even maybe exposed. The functionality of a hospital. What is the CEO going to do? What is the medical manager doing? Because in my internship, I got to be exposed more to what actually happens, in managing, other medical practitioners. So I think at med school, something of that nature should be also either incorporated or at least experience that. I know it's something which is sort of not something that comes already in one's mind if you're in medical school, but I think that's one thing that I would also have loved, to participate in. And of course, the last thing is there's something about the professionalism that just, I don't know what happens to it, but first year keen, enthusiastic, you want to do everything, the years go by, you sort of, you're in I don't care mode. I just want to finish and go, so I feel like there's a lack or a time or a space for more of the professional aspect of the profession. Yes, of course, sometimes I think it's difficult to teach one to be professional. There are guidances, there are core competencies, whatever it may be, but there is more, that one can, come out of with at med school. And I think lastly, one thing that I would have done different at med school is to actually educate myself financially. I've made bad financial decision in my internship, which I think if I had known as a medical student, I would have not done. So yeah, please do take time and read something about finances, especially if you are from a background where you've never managed so much money that you get in internship. So yeah, that's for me.
Thanks, Dr. Muhango. That's great. What would I say to myself at medical school? Balance is important. I think medical school and internship and just doctoring can become quite all-consuming. And one of the best things I did was deciding to add balance to my life, and I realized it quite late. So I decided to start to learn to play an instrument, and I decided that last year. So now I can play the drums, which is pretty awesome. But I wish I'd done that at medical school. It was all about learning and getting through and going to lectures so that you could be that doctor. Because when I was at Wits, we had quite a strong ethos of, if you don't know this, someone's going to die because you don't know it. So we came out quite terrified that we were going to kill someone through lack of knowledge. And we were trained like that. And it was quite terrifying to go through a program like that. And when I got to internship, I realized it wasn't quite that severe. But I wish I'd gained the ability to balance my life a bit better at medical school. And I'd like to encourage you to do so. So live your life, have your kids, don't wait, get married, travel, go overseas. Because if you do wait, you will, the course that you may set yourself on in the medical program, you're a lifelong learner. The degrees will come, it gets harder, you have to study more, and your time will just become less. So I think don't wait to do the things that you want to do, and be a great doctor at the same time, because the balance will provide you with the skills to be just that. People want you to be human, and I think our program can sometimes dehumanize people, and the human element is what your patients want from you. So cry with them and don't be afraid to show your emotion, because it's not a sign of weakness. It's a sign of empathy and solidarity, and most patients feel better just from getting that from you. So that's from me.
It's very hard to follow what the two doctors before me had said. I agree with all of that, 100%. I think from my side in medical school, we obviously form great friends in medical school, because you're already together, you form a bond, and that bond is almost always long lasting. But what I do regret is I've lost a lot of those bonds because of the work. And that's what's going to happen to a lot of people if they, especially someone like me who went straight into it. I love my friends, but I've been unkind to them in that I've lost touch because of the work. And I think that's what Dr. Ingratta is trying to tell you, is that the work will always be there. There's no shortage. There's plenty of sick people out there. There are desperate people. They're going to need you. And the better you are at your job, they're going to need you more, and they'll appreciate you. And that's also very true. But the other people that you need and who need you are your friends and family. They also need you. They're also going to lose you. You're going to lose touch with some people if you start off very early. Not from lack of trying, but just from commitments. And that's something it's very difficult to get back. So if I was in medical school today, I would still probably have followed my path, but have tried somehow. My day we had text messaging only came out, I think, when I was midway through my mid-reg career. And then there was no such thing as an emoji. It was a dash and a question mark and a asterisk, and that made a happy face. So, we lost touch, and we had to pay for it. There was a rate, SMS rate, which we didn't have a budget for at all. There's no such thing as Wi-Fi free. So you lose touch, and you've got the opportunity where you've got platforms like this, you've got social media where you can stay in touch. So I encourage you to keep staying in touch with your friends. They also will be busy. They'll also have a hard time keeping in touch with you and staying in touch with you. But now you've got the benefit of technology, which makes that a bit easier. So don't use it to read the fake news. Use it to stay in touch with your friends and your family, and stay that way, because those relationships do tend to start fading away as the work becomes more and more demanding, as your career takes off, as the patient load becomes worse and worse and worse. And I suppose in the future, as your remuneration also becomes more and more difficult, because it's a well-known fact that our salaries, whether it's in the private sector or the public sector, does not keep up with inflation. Doctors we are early well paid relatively, but we are not well paid later on in terms of what other people working the hours we do earn. So you end up still having to work, which means you have less and less time for other people. So just remember that and stay in touch with your friends and family. Thanks.
Thank you very much, doctors. So we just have a few questions that students submitted before the event and also from students who are currently viewing right now. So I'm going to start with this question. I won't pose it to a particular doctor, but anyone who feels like they can answer this is more than welcome. Answer the questions is more than welcome. Someone asked, can you take a break, like a gap year after 6th year, and how will that work?
I'll go. You absolutely can. It's just that I wouldn't suggest doing it right after the 6th year, purely for logistical reasons. Getting a post, an internship post, is a story and a half. So I would just like tough it out, do internship, do ComServe, and then maybe take a break. Purely because I don't know what happened in previous years. There've been situations people don't get posts. Getting a post in the as an asynchronous person is also quite difficult. You might have to wait for a while. The rules are always changing. So I would suggest, sort of getting your required time that's legally required for you to be an independent practicing doctor out of the way, and then taking a break from medicine if that's what you want to do.
Okay, thank you. Someone asked about what the safety is like for a female doctor in a rural setting.
Okay, I'll go. So yeah, safety is actually a big concern, particularly in the peripheries, not only for yes, of course, particularly for females, either doctors or females in general, but I was in a rural area, but the hospital was in town. I don't know if it makes sense. So the town part of the rural area, that's where the hospital was situated, meaning that it's well off safe, But some rural areas I've heard of experiences where there is no security, People are almost, I'm sure you would have heard, people are almost, there were instances of sexual assault in the hospital, So there is a bit of a concern with safety. And again, I think this is another part. Maybe I think as a consideration for choosing where you go for intern, I think safety might be one of them. But there is really much that the Department of Health is doing when it comes to safety, either of patients or of the healthcare workers, particularly in the rural areas. It becomes a whole lot of political things. Security must be attained up by the Minister of Security and what. It's not part of the Department of Health's job, So there is a concern about safety. That's actually a great concern. And I think it's something which definitely, I think, is still being raised, by the people in the leadership positions, Yeah.
So I'd also like to come in there. I went to a rural place in rural Mpumalanga. I went to St. Rita's Hospital in Jane Firs, which is about 150 kilometers from anywhere. My advice to you and what we did, we went as a group for ComServe, so we were strategic when we chose. We saw how many posts they had and we applied as a group. So 3 of us went together and we lived together in the res, and it was safe. The second thing we did is we actually went to the hospital before we made our decision. So we drove there to take a look around and just to see what was in place. And if you have that option, I would highly recommend that you do that. Most intern placements are, by their very nature, quite well supervised, well covered in terms of staff and security. The more rural facilities, that's where there might be a lapse. And that's why I'm saying if you can, just go and have a look.
Thank you, doctors. We have quite a few overseas questions, so I'm going to group them all together and direct those to our specialists. So the questions are, community service. Someone just wants clarification on community service. Do you have to do community service in South Africa if you want to specialize overseas? And how does specializing overseas in general work?
That's a really tough question because the answer is it depends. For most overseas universities, they will not take you until you had completed your local training. So that includes community service. So you have to actually have completed community service before you even consider applying. Before, about 10 years ago, you could go overseas and do your internship there, but that's no longer the case. Not with the local degrees that exist being quite different to the overseas degrees. So the short answer is, if you are intending to go overseas and you have an idea of where you want to go, then Google those programs and see what their requirements are, and write to those program supervisors and find out what the requirements are. Because, for example, to go overseas and do medical officer training is actually pretty easy. And our passport allows you to travel to quite a few places without much difficulty. One of those examples is like Ireland. The UK loves South Africans, and our passport allows us to freely go there. The US is difficult to get into because you have to usually do the USMLEs, which is a whole series of highly expensive exams that you have to fly there for. In terms of specialization, if you specialize here, there is no automatic guarantee that your speciality will be accepted and recognized overseas. In fact, the rule is they often demote you to your previous level to train. So if you're a cardiologist here, you will be demoted to a physician to train and then have to do cardiology again. That's kind of the rule for specialization. So my advice to you is, if you want to go overseas after ComServe or after a medical officer time. But to go after specialization, you're going to have to redo part of your degree over there. I hope that helps.
Thank you, Doctor. So we have a few questions about pursuit of other professions and other endeavors. So someone is asking, what are the possible non-medical and non-academic professions you can pursue after ComServe? So kind of where you can have a life. And from your experiences, is the pursuit of other professional endeavors outside of the medical field possible or feasible?
Yes, it's definitely possible. In fact, a lot of the people in my class or my year or my graduation year often left the clinical medicine, the aspect of clinical medicine, and they went into different things. There's a lot of opportunities. In fact, the industries out there are very, very much looking for qualified doctors with an MBBCH degree, who then do something else, and it's mostly in different fields. So you can look at management fields, where you become a health manager, a hospital manager, or superintendent type of person. That's really to do with personnel allocation and so on. A lot of that aspect also entails financial management. So it's a lot of accounting and budgeting and so forth. And they really want those kind of people who have a medical background because they understand the nuances of some of these decisions in terms of finance. There's also a lot of opportunity for research in the pharmaceutical industry. So you can, even after your MBBCH degree, you can even do something like chemical engineering sort of background or diplomas, and you can move into that sort of space. And the private sector, of course, in the pharmaceutical industry is really looking for those kind of people. You could, of course, specialize as well all the way and then move into a research degree or a research field where you may no longer see patients clinically. You may not be on call or do ward rounds and so on, but you're literally in some sort of research institute where you collate data. And that would be very office-based and office hour-based with no calls and so forth. There's a lot of opportunity for that. Not all of these things necessarily entail you needing to acquire a degree or study something further. You may just move into that space. In fact, most of the sort of medical advisors on some of the pharmaceutical industries, even the healthcare industry, such as the medical schemes like Discovery and so forth, they often employ doctors with basic MBBCH degrees and so on, but as advisors. And these people sort of learn as they go. They work through the fields and they acquire sort of skills there without any formal training or exams to be written. So there's a lot of opportunity for that. There's a lot of opportunity in the public space as well for managers and people who have qualified as doctors essentially, but moving to managerial positions. In the past, you didn't need to actually write a degree or study for anything like that. But I think today the competition out there for these managers is becoming a bit more intense. A lot of people want to move into that space, so they will obviously look at further qualifications if you have them. A lot of people do a MBA. Usually you can do that MBA even during your internship or in your comm service year. You can do it part-time. You usually get modules, you attend very few lectures, and you generally have to write some sort of research project or thesis, and you'll be granted with an MBA. That also opens up a lot of doors for you. It's a business administration, but that can take you into the financial space, the managerial space, and even later on into the research space.
Yeah, I also wanted to say that I think the lens that you have on the opportunities at medical school is quite limited. It's very easy to think that the only stuff available is the stuff you rotate through. But what you don't realize is you can go all the way through medical school and realize that you don't actually like people. And then you can go into different fields such as pathology and forensic pathology, where you can cut up people. Maybe that's your thing. Or you like to look at microscopes and you want to go and look at cells, and there's pathology for that. And going into the lab work. So all of the aspects of what we do every day, not just the clinical part, you are valuable in all those aspects. And the MBBCH degree is one of the few degrees where you are guaranteed a job as you leave, certainly in the field. It's very unusual to find an intern not get a job. That is not the case in engineering and in law and in all of those degrees. So it's very highly sought after as a doctor. And if you decide you don't want to be a doctor during your degree, that's very difficult at some places, because it's difficult to step off in the middle of the degree into something else. But you have to check at your university and other universities if they can accommodate you. If you decide halfway through, you're just not keen. But yeah, definitely lots of opportunities in the field as a doctor, and people want you for all sorts of things. You just may have not seen it before. So use your elective programs to go and discover these things that you've maybe not heard of. Travel overseas, do overseas fellowships. Look, I know we're locked down, but the opportunity for students to travel overseas and do fellowships and be funded for it is massive. Students just don't know about it. And the local coordinators at your universities that manage your electives do have that information, and you should ask. So you can travel while you're a student as well.
Okay, we have a question posed at our intern or our community service doctor, whoever wants to answer this. Someone just wants to understand what it means to be responsible for patients. So I think our intern earlier mentioned that they would be responsible for 20 to 30 patients. Someone just wants to know what exactly this means and basically what it entails to manage a patient during internship. Like, what are you doing for each patient?
So from the intern perspective, well, it depends on what rotation you're in and which department you're in. So let's say in neonates, which was the scariest thing I've ever done in my entire life. So I would go in the morning, basically review every patient in my cubicle, which is about 12 patients. That means looking at the history, asking mom how baby is doing, looking at vitals from overnight, seeing where we are with fluids and feeds, and a quick examination, and then you basically arrive at an assessment, which is like different. I feel like in med school, you're sort of taught to make an assessment in terms of what is the diagnosis acutely, but like when you see patients in the ward, you need to like decide where they are in terms of, are they getting better, are they getting worse, do they have complications? And then you need to decide what you're going to do for the patient. So in neonates, are you going to continue antibiotics? Are you going to stop antibiotics? Are you going to do bloods today? Does the drip need to be changed? And then you do a round with your reg or your consultant, and then they ask you to do certain things like book scans, to pull these bloods, to change the drip, to put in a catheter, so that's what being responsible for a patient is. So you see them, and then you put in whatever pipes need to be put in. You take out whatever pipes need to be taken out, and then you book things for them. You call allies. You book them for CTs. You consent them for CTs. If you're in surgery, it means you also sometimes consent them for things like scopes, also for scans as well. Sometimes being responsible for a patient means pushing a patient who's like 150 kilograms from like the fourth floor of one building to radiology, which is on the other side of the hospital, to a fellow intern, lifting them onto the CT machine, then lifting them off the CT machine and taking them back. It means like staying after hours if you worry that your patient has a PE. If you're worried your patient has a PE, and then you've resuscitated them, you've talked to your seniors, and then that means you now need to talk to the radiologist about getting an urgent CTPA. No, so that's what it means to be responsible for a patient, to sort of making sure that things happen for them. Ordering blood for transfusion, making sure they have a line, checking the blood with the sister, starting the transfusion, making sure they don't have a reaction. So that's what it means to be responsible for a patient. So basically making sure they stay alive and that they get better by doing all these different things each and every day.
I think I'll just add, I think Dr. Sibanda covered all the basic what it means to be responsible for patients. But I think another part which we sort of, I think from med school, are not so much, it's not so much emphasized, which is record keeping, So I think the government is slowly moving away. I know of cases where actually interns, it's unfortunately happened between two interns. One intern's mother passed away from another hospital, under the supervision of another intern. So they went into the hospital, saw that, the mother was neglected, the notes were written by this intern, so, and then the rest that do just HPCSA, and HPCSA is just looking into that case. Yes, as an intern, you are supervised, and there's a senior person who is supposed to be responsible for, let's say, the whatever legalities that may arise from that particular management of that patient. But I think as an intern, the responsibility is to make sure that you keep your records. I know we hate writing, but record keeping is one of the things which sort of ties you down to say you are responsible for saying continue management, continue MX, whatever you write, it's the court, whoever it is, can come and say, but this is you, and you might be called actually to come and explain in case of any instance. So I'm just saying, I think another responsibility which is that we sort of have is to make sure that we record keep, and you can be called. I think the Department of Health is slowly moving away from trying to pay the negligence or whatever cases are that people sue and pin it actually to the doctor responsible or whoever was responsible for that particular case, if let's say we are found to be responsible.
Okay, thank you, doctors. And our final question for this evening, what are the doctors' views on the field of sport and exercise medicine, and is it a field worth venturing into? Are there any negatives?
Okay, I'll go. I think, but the seniors will take this one. But I'm just going because actually there is some of my seniors from residency. They finished their ComServe and did some MO time, But now actually they've sort of taken that route, and they are like medical doctors for sports teams, in the PSL, the local league for soccer, So and then actually I was chatting to the guy a few weeks ago, saying actually was trying to recruit me to come and join him. It's a bit different because, of course, if there's no soccer, there's no injuries, but you're still getting to do your sort of day-to-day work, which is to check on these soccer players. So I think from the experience of the colleague, I think it's actually a great field as well to go into and the experience. And of course, it's more in terms of fixing. So I think there's quite also a variety in terms of sports medicine, because your cruciate ligament, your meniscal tears, all those things, they are more like orthopedic subspecialty. So it means one will have gone through that route. But then there is just general sports medicine where we are managing whatever acute injuries need to be managed for particularly those in soccer. That's my experience that I have. But yeah, I think the seniors will take that.
Yeah, look, sports medicine is quite an advancing field. There's obviously a lot of interest in that. It's very financially driven, the interest, because these players, when they get injured, there's millions of rands or dollars or pounds at stake for the team and the league and the whole industry as a whole. So a lot of the, as Dr. Muhango said earlier, the patients may actually be referred to someone like an orthopedic surgeon or plastic surgeon or someone that can actually fix the problem if it's serious enough. But the sports medicine person is literally to look at the extent of the injury initially, and then the duration during which that player may not be able to financially contribute to their side. So there's a lot of pressure there. I think it's quite a political job. It's obviously a nice field because there's a lot of science behind it as well. But it ends up being, I would say, very much an industry-driven field for most people when they get to those kind of levels. From an everyday level, just treating your average sort of part-time athlete or individual athlete, of course, there's a lot of scope for that. And of course, as you know, the world is realizing the importance of daily and rigorous exercise in terms of general health, cardiovascular health, diabetes, and so on. So you will see a lot of that, but a lot of